Greetings from the World Health Organization. My name is Chandra-Mouli and I work for WHO's Department of Sexual and Reproductive Health and Research, and I lead the work on adolescent sexual and reproductive health. So I welcome you to Module 5 in the Geneva Foundation for Medical Education and Research and WHO Eastern Mediterranean Regional Office course on adolescent sexual and reproductive health. This slide contains a definition of sexually transmitted infections. As shown on this slide, they are infections caused by bacteria, viruses, and parasites transmitted through sexual contact, including vaginal, anal, and oral sex. Some STIs are transmitted through skin-to-skin sexual contact and through non-sexual means. For example, from mother to child during pregnancy and childbirth, or through a blood transfusion. And there are a number of bacteria, viruses, and parasites that cause STIs. This is one of two slides which provides the rationale for attention to and investment in STIs. One, STIs among adolescents are an important problem. Although there's a lack of data on the incidence and prevalence of STIs in adolescents globally, where studies have been carried out or surveillance systems are in place and they gather information about adolescents, we see that adolescents represent an important population who are infected with sexually transmitted infections. The second point is both adolescent girls and adolescent boys are vulnerable to STIs. In the case of girls, as shown in this slide, there is both biological susceptibility and social susceptibility because they are under pressure in many contexts to have sex which is unsafe and unwanted, and even in stable relationships they are exposed to partners who are themselves infected through multiple partner sexual activity which is unprotected. Adolescent boys, on the other hand, are susceptible because they are under pressure to demonstrate sexual prowess and to have multiple partners. And often because of social norms, they feel under pressure to have sex with sex workers, which also increases their vulnerability. This is the second of two slides which deal with rationale. It makes 3 points. One, STIs among adolescents have major health consequences. The immediate consequences are shown on this slide, but there are serious long-term consequences. For example, gonorrhea infection which can be passed on from a mother to a baby at the time of childbirth, or chlamydia infection which, if left untreated, can cause infertility. The second point is that the prevention and management of STIs has been shown to be effective. Proven approaches are available to diagnose and to treat several STIs, but not all of them, especially the viral ones. The third point is that we need good quality prevention strategies and good quality care and management services. And prevention strategies include HPV vaccination. There's growing recognition that where prevention strategies and care strategies are in place, they do not respond well to the needs of adolescents. This clearly needs attention. Just like we've done in the 4 previous modules, in this module we set out human rights obligations. States have obligations to ensure care and treatment of STIs to adolescents as part of a package of sexual and reproductive health services. States are obliged to ensure that STI services are accessible to adolescents, are free, confidential, and non-discriminatory. And states are also obliged to remove barriers such as third-party consent requirements. So clearly, what needs to be done is enshrined in international law, in human rights law. In addressing STIs in adolescence, there are two key concepts to take into account. Firstly, adolescents lack knowledge and understanding about STIs and about STI prevention and management. They really need to be informed about this. And they also need to be informed about HPV vaccination and how to access HPV vaccination, human papilloma virus vaccination. In most places still, this is available only to girls, but in a growing number of high-income countries, this is available to girls and boys, and this will evolve with time. The second point is that where STI prevention and management services are in place, they do not reach adolescents, and even if adolescents reach them, they do not respond to their needs. And this is clearly an area that considerable effort is needed. Building on the point made in the previous slide, adolescents need comprehensive sexuality education. The UN family has come together and developed guidance for delivery of sexuality education in the school context as well as in the out of school context. And this has been discussed at length in Module 1, as also discussed in this module. And there are 3 points to make here. Firstly, children and adolescents need and have a right to sexuality education. Secondly, sexuality education does not harm children and adolescents. This is a common misconception, but there is considerable evidence that they don't harm adolescents or children, and in fact, well-designed and well-delivered sexuality education programs can do them good, can improve their knowledge, their understanding, promote safe behaviors, and when combined with a package of interventions can promote improved health, can contribute to improved health. This is one of 2 slides which address guidelines developed by WHO to address STI. This particular slide addresses diagnosis and management of a whole range of STIs. As you can see listed on this slide, there are a number of individual guidelines to address individual STIs. Efforts are underway to bring all these together into a composite document which can address all the STIs as a package. This is the second of 2 slides that deals with guidelines, and this particular set of guidelines deals with public health policy and strategy development and execution. So here, as you can see, there are a number of guidelines which deal with specific population groups, and such as men who have sex with men, transgender populations, sex workers, people living with HIV. And then there are documents about cervical cancer control, addressing children and adolescents who have been sexually abused and addressing STIs within that context, and then using brief sexuality-related communication as part of a wider public health approach. This slide contains a number of documents published both by WHO and by other organizations which address STI. They are not part of WHO's guidelines, but they contain valuable complementary information. All these materials are available on the website, and they're available with the Geneva Foundation for Medical Education and Research database. But if you require any help in acquiring these documents, please do reach out to me at WHO. In this and the next two slides, I'm going to address responding to STIs in the context of COVID-19, just like we have done in previous modules. So this document, which is titled Not on Pause, actually sets out actions that can be taken by program managers and service providers to address STIs in adolescents in the context of COVID-19. So there are 4 points on this slide. First of all, informing adolescents about where and how to access care using a variety of means. Secondly, in health facilities, ensuring the availability of diagnostics and treatment. Thirdly, ensuring the availability of condoms and promoting their use. And fourthly, waiving restrictions where they existed on age, marital status, consent, and on fees. So these are specific measures. This slide contains 4 other points to complete the list. The first one is to prioritize testing for adolescents who are at higher risk. Secondly, to encourage adolescents presenting for testing and care to bring their partners, to refer their partners. Thirdly, where possible, to provide home-based HIV and other STI tests, as well as information about self-sampling and where to send samples. This may not be possible in many places, in all places, but where it is available, this needs to be tapped into. And then lastly, where possible, to use digital platforms and mobile health strategies to minimize clinic visits, to provide adolescents with test results, treatment, and prevention messaging, while ensuring privacy and confidentiality. So to try to ensure that despite the closures and the disruptions caused by COVID-19, services can be provided. The Not on Pause document sets out considerations for resumption of normal services in the context of COVID-19. And I've just pulled out 2 points to highlight here. One is to run up catch-up campaigns for HIV and other STI treatment. And secondly, to promote the institutionalization of good practices that have been developed in the context of COVID-19. For example, approaches to make services accessible, to promote condoms, or to set aside barriers to access, to try to ensure that these are institutionalized and become the norm even after COVID-19. This last slide is a cartoon by Graham Ogilvy, someone whom we've worked with for many years. And it points to clearly one of the central issues in providing effective prevention and care services, and that is the health worker and patient or client relationship, which needs to be based on trust, needs to be based on non-judgmental interactions and respect. And this is the basis of the brief sexuality communication work, but needs to be part of all exchanges with clients, but not just adolescent clients, all clients in the context of STI prevention and care. With that, I conclude the global segment of the presentation. I'll now pass on the baton to my regional colleague, who will present a regional overview on STIs and point to what are the special implications for this in the Eastern Mediterranean region. Thank you.
Welcome to Module 5. This is STI Prevention and Cure, a regional perspective from the Eastern Mediterranean region. I am Dr. Bridget Mugisa. I work with the World Health Organization as Technical Officer for HIV, Hepatitis, and STIs. I'm based at the regional office in Cairo. So this slide shows the global and regional situation, the STI incidence and prevalence In 2016, the World Health Organization conducted estimates for the 4 curable STIs, that is chlamydia, gonorrhea, trichomoniasis, and syphilis, globally and by region. And you will see on this slide for the Eastern Mediterranean region, 34 million new cases were estimated. Also on this slide, you'll see the prevalence estimates for the 4 curable STIs for males and females aged 15 to 49 years, and the breakdowns are shown in the table below as well. In terms of the regional situation, awareness, knowledge, and misconceptions, a survey of people aged 18 to 25 years in Saudi Arabia in 2008 showed that 56% women were completely unaware of their sexual health. Only 60% knew that condoms do not provide 100% protection from all STIs. Another study in Iran involving men and women engaged to be married showed that only 4.5% people knew that a person with STI does not necessarily look ill. This study also showed that 78% were not aware that painful urination could be a sign of an STI. 51% were not aware that the presence of sores in the genital area is an STI symptom in both men and women. A study in Egypt and another study in the United Arab Emirates involving university and college students showed that only 20% of the participants knew that if one person is infected, sexual partners need to be tested and treated. Almost 70% believed that they were more likely to be infected when they were menstruating, sharing toilets, using swimming pools, as well as physical contact, such as handshaking and hugging. In terms of beliefs and attitudes, the negative beliefs and attitudes towards people with STIs and about provision of sexual reproductive health, education, and services are prevalent in the region. A study in Pakistan conducted in 2013 showed that women with STIs tend to be more subjected to more blame and judgment compared to men, and this gender-related discrimination was considered normal. More women than men believe that there is no need for sexual education for Muslims, believing that STIs are not an issue among them. In Saudi Arabia, a study conducted in 2008 showed that although 90% believed that their partners had the right to know if they had an STI, 55% of these said that they would ask for a divorce if their partner had an STI. Another study in Iran in 2013 showed that 62% of the participants believe that education about STIs and unintended pregnancies does not lead to premarital sex. And at the same time, 62% of males and only 27% of females believe that young people should have access to contraceptives, including condoms, before marriage. The policy situation for STI prevention and care in the Eastern Mediterranean region. There was a survey conducted in 2019 with participation of 16 countries. And from this survey, 13 countries reported having a national policy or guideline in place for STI diagnosis, treatment, and counseling. 9 countries reported a national policy and guideline that aligns to the global health sector strategy. That's the 2016 and 2021, which is the latest one, as well as the WHO guidelines. And 8 countries stated that the national policy on STIs requires use of an STI surveillance system to monitor the progress to global STI targets. 11 countries reported having a national policy in place that aims to reduce gonorrhea incidence. There are a number of regional challenges. The first is slow policy adoption. There is a discrepancy between policy formulation and implementation, which may be due to lack of resources, infrastructure, and finances. 2, there's lack of knowledge. Sexual health is not taught in any formal settings in the countries in the region, leading to poor knowledge on sexual and reproductive health among adolescents. For example, a study in Saudi Arabia showed that the major sources of information on STIs among respondents were the internet, books, TV, friends, magazines, and family. The third challenge is age restrictions, placing the conventional or widely accepted legal age of consent at 18 years and ambiguous policies preventing access to HIV testing among minors who were sexually active and are at risk of infection. There's also misconceptions among both the educated and uneducated populations, For example, a study examining physicians' knowledge in Saudi Arabia reported that almost half of them identified casual kissing as a mode of HIV transmission. Social cultural factors such as conservative laws and social disapproval for sexual health education significantly influence sexual health awareness and safe-sex practices in the region. There's also low perceived risk due to social and cultural factors. STI rates are not commonly reported in many countries, which might contribute to perception of low risk among many Muslim countries, as highlighted in a systematic review looking at the attitudes among Muslim women. There's also service provider attitude with negative and judgmental attitude of care providers towards people attending STI services. Another challenge is cost and infrastructure. A study in MENA and North Africa documented that the reason for not using condoms included partner refusal, high condom prices, low perceived risk of infection. Countries like Afghanistan, Sudan, Yemen, Syria with humanitarian settings have poor infrastructure and significant gaps in provision and access to services. There are also weak health information systems with low reporting of STIs having a bearing on disease burden. For example, low reporting of HPV and its relation to cervical cancer. This slide highlights the best practice in the region from an NGO called MASA based in Lebanon. MASA is an NGO which is currently in Beirut, and it was established to provide holistic sexual health care in 2011 with support from the World Health Organization, the Arabic Foundation for Freedom and Equality, as well as the National AIDS Program. So the aim of this NGO is to provide sexual reproductive health services to adolescents, to adult women, to socially and economically vulnerable groups in multidisciplinary team, in a safe environment, free of judgment and friendly to improve uptake of services by the beneficiaries. So in terms of the services, MASA provides a comprehensive set of services with information and education provision aimed at both improving literacy among the beneficiaries, also improving sexual health education and communication with sexual partners, voluntary counseling and testing for STIs and HIV at a subsidized cost, cervical cancer screening, medical consultation with doctors and dermatologists who have specialty skills in STI management, psychosocial counseling and alternative therapies, promotional outreach campaigns, e.g. on how to use condoms. So some of the key features of MASA are: one, being able to provide a comprehensive package of services; two, assurance of a non-judgmental environment with full autonomy and confidentiality for patients; and three, provision of services by highly skilled, trained, and a friendly team of staff. In terms of the regional opportunities for STI prevention and cure, these have been aligned to the World Health Organization Global Health Sector Strategy on STIs, as well as the Eastern Mediterranean Regional Framework and the Action Plan for STI Prevention and Control. Both these documents emphasize the need for an integrated approach to STI prevention and control through securing universal access to sexual health and reproductive health care services and rights. So some of the key priorities, the key elements include: one, increasing access and coverage to testing and treatment of STIs; where feasible, promotion of integration of STI services into other programs, e.g. HIV and hepatitis; three, adoption of use of multiplex technologies for testing, such as dual testing for HIV and syphilis; four, promotion of use of prevention interventions to high-risk groups; five, resource mobilization for STI programs; and finally, continued advocacy at policy level to ensure that they are in alignment with the global recommendations. The next slides include references that can be used for your resources for further reading on each of the key elements in this module. Thank you very much.